Distributive shock without bacteremia, a rare case of staphylococcal toxic shock syndrome due to presence of breast expander. Toxic shock syndrome is a rare, life-threatening complication of some bacterial infections, typically seen due to presence of a foreign body. Treatment requires prompt recognition and removal of the foreign body to achieve source control. We present a case of toxic shock syndrome caused by MRSA after breast tissue expander placement. This is a case of a 41-year-old female with history of right breast cancer status post-mastectomy who presented with acute onset fever, vomiting, diarrhea, and abdominal pain. Her symptoms had rapidly worsened within a few days. Her mastectomy was performed in June 2023 with expander placement. Initial expander was removed after 2 months due to infection with Serratia. Second expander was placed after 4 months. She presented to the ED 2 weeks after the expander placement. At the time of presentation, she was hypotensive with her initial blood pressure of 67/31, tachycardic, and febrile, requiring initiation of antibiotics, vasopressors, and admission to the ICU. She was hypoxic and required intubation. Her serum lactate, creatinine, BUN, and transaminases were elevated as well. Her CT abdomen pelvis showed findings suspicious of ileus, which was initially suspected to be Clostridium difficile, but turned out not to be. Her condition started deteriorating rapidly within 24 hours of admission. She required 5 vasopressors, including norepinephrine, phenylephrine, vasopressin, angiotensin, and epinephrine. IVIG, methylene blue, and albumin were also given. She was anuric and started on continuous renal replacement therapy. The choice of antibiotics included vancomycin, cefepime, and clindamycin. She developed significant thrombocytopenia requiring platelet transfusion. Her labs were suggestive of DIC. Fibrinogen and platelet count were low, PT-INRD dimer were elevated. There was no focus of infection found on imaging, and she had no open wounds. The likely source of infection was thought to be the breast expander. This was confirmed when cultures from the JP drain grew MRSA. She was taken to the OR emergently for the removal of breast expander, after which her condition steadily improved. She was weaned off vasopressors and extubated successfully. However, her skin was mottled, and later she started developing a desquamative rash all over the body. She was transferred to a burn unit for further care. In the discussion, I would like to highlight the rapid onset of hypotension, multisystem organ failure, and rash with negative blood cultures pointed to toxic shock syndrome. Toxic shock syndrome should be suspected in patients with hypotension, multisystem organ failure, and rash. The classic desquamative rash is not always present initially and may develop later. High index of suspicion is needed. Early surgical debridement, removal of infected foreign body is critical in treatment of this patient. It is vital to be aware of clinical pictures so as not to delay treatment. We report a case of toxic shock syndrome secondary to infected breast expander which was successfully managed.